Welcome, curious minds, to another deep dive. Today, we're putting on our medical detective hats, you could say. We're exploring a really intriguing frontier in mental health. How our physical brain, well, when it goes off script, can directly shape our thoughts, feelings, and behaviors. We've got a great stack of sources you provided, and we're sifting through them looking for those critical clues and maybe some surprising connections. Our mission really is to unpack the intricate link between brain function and conditions that often look like typical mental health challenges, helping you spot the difference. Okay, let's unpack this.
Yeah, it's fundamental, isn't it? The idea that every single psychological process, thinking, feeling, perceiving it all springs from the brain. But when we talk about organic mental disorders, we're actually honing in on something very specific. These are conditions where we can pinpoint a clear, identifiable brain disease or physical problem that's causing the mental health symptoms. It might be a problem starting, directly in the brain itself.
Like a tumor or injury.
Exactly. Or it could be a body-wide illness that's secondarily affecting brain function, like, say, a thyroid problem. And this distinction is crucial, not because other mental health conditions lack a biological basis, we know they often do, but because in these organic cases, we have a concrete physical cause we can often diagnose and, importantly, treat.
Okay, that makes perfect sense. So our sources seem to break down psychiatric disorders into, like, three broad buckets.
That's a good way to put it.
First, those with a known physical cause affecting the brain are organic mental disorders for today. Then there are those where, well, a physical factor hasn't been found yet. And finally, those primarily linked to psychosocial factors. So we're really zeroing in on that first group today, where the brain's wiring or chemistry has demonstrably gone awry.
Precisely. And here's why it's so critical in practice. A physical brain illness can cleverly mimic any psychiatric disorder. Yeah, from depression to psychosis, anxiety, you name it. That's why it should always be the first thing clinicians consider when someone presents with new psychological or behavioral changes. We call this having a high index of suspicion for an organic cause.
Okay, so what raises that suspicion? What are the red flags we should be looking for?
Well, several things really set off alarm bells. Symptoms appearing for the very first time, that's a big one. A sudden onset, especially if the person is older. Also, if there's a history of drug or alcohol use disorder, that always needs consideration.
Okay.
And if they have other concurrent medical conditions or neurological illnesses already diagnosed, or new physical symptoms cropping up, think seizures, problems staying conscious, maybe a recent head injury or issues with sensation or movement.
Right, actual neurological signs.
Exactly. And critically, if you notice confusion, disorientation, memory problems, even subtle neurological signs.
Subtle, like...
Maybe a slight tremor that wasn't there before, or a change in walking that isn't quite paralysis, but just suggests something isn't quite right. Those soft signs. And unusual hallucinations are a major red flag, particularly visual ones or those involving smell, taste, or touch, which are less common in, say, schizophrenia.
Those are really powerful clues for our medical detectives, then. So once that suspicion leads us down this organic path, the sources guide us through four main types of disorders we'll explore.
That's right. We'll look at delirium, then dementia, then organic amnestic syndrome, and finally a sort of catch-all group of other organic mental disorders.
Okay, let's jump into delirium first. You mentioned it's actually the most common one seen in hospitals.
It is incredibly common. It affects a surprising number of patients in general medical and surgical units, especially common postoperatively.
And it used to be called acute confusional states, right?
Yes, exactly. Delirium is the more precise modern term, and its features are quite striking when you see it. Imagine someone whose world just suddenly becomes foggy, unclear.
Like a literal clouding of consciousness.
Yeah, that's the term, yes. Clouding of consciousness. Decreased awareness, difficulty responding.
Yeah.
They might not know the day, the date, maybe even where they are disorientation.
So time goes first, usually.
Often time, then place, then person, typically. And their attention just bounces around. They're easily distracted. A real hallmark is marked perceptual disturbances, primarily visual illusions, misinterpretations, or outright hallucinations, seeing things that aren't there.
Wow.
Their sleep-wake cycle is often completely haywire. Maybe agitated and awake all night, then drowsy during the day.
Is that the sundowning thing I've heard about?
That's part of it, yes.
Yeah.
Symptoms often get worse in the evening or at night, sundowning. They also struggle to register and retain new memories while they're delirious. And you see psychomotor disturbances. They might be really agitated, restless, or conversely, very slowed down, lethargic.
So it can go either way.
It can. And then there is some fascinating, more specific physical signs you might see. Things like asterixis, that's a flapping tremor, often seen when they hold their hands out. Multifocal myoclonus, sudden brief muscle jerks. Sometimes even carphologia or floccillation, sort of purposeless picking movements, like picking at the bedclothes.
That sounds quite distinctive.
It can be. And then there's occupational delirium, where they might actually pantomime actions related to their job while lying in bed. Quite surreal.
That paints a very clear and, frankly, quite concerning picture. And you mentioned something absolutely vital earlier, that delirium is often missed.
Tragically, yes. It's often missed or misdiagnosed, maybe as dementia or just agitation.
But catching it early is paramount because the underlying cause is so often correctable, right?
Absolutely crucial. If we identify and treat the underlying cause quickly, the delirium often resolves completely. But if we miss it or delay treatment, it can lead to permanent brain damage or worse outcomes. The diagnosis itself is clinical. There's no single lab test for delirium, but tests are absolutely essential for finding the etiology, the root cause.
Okay.
The diagnostic criteria, like from the ICC-10, really emphasize this global disruption. Impairment of consciousness and attention, disturbance across cognitive functions, psychomotor changes, the sleep-wake cycle disruption, emotional disturbances.
And the key features are the rapid onset and fluctuating course.
Exactly. It comes on quickly, usually hours or days, and the severity can fluctuate wildly throughout the day. And it's generally short-lived, less than 6 months if treated. Certain factors make people more vulnerable, of course.
Like what?
Pre-existing brain damage, being very old or very young, having a history of alcohol or drug dependence, chronic illnesses, major surgery. These all lower the threshold. It's often described as a threshold phenomenon. Think of it like multiple smaller stressors pile up, maybe a mild infection, a new medication, dehydration, and together they overwhelm the brain's coping mechanisms, tipping it into delirium.
And here's where it gets really interesting. You mentioned the sheer range of triggers for this. It's kind of mind-boggling.
It truly is. The list is extensive.
We're talking everything from metabolic issues like low oxygen,
Hypoxia, yes, or a hypoglycemia, low blood sugar.
endocrine problems like thyroid dysfunction,
Definitely, both overactive and underactive thyroid.
and then a massive array of drugs, both taking them and withdrawing from them.
Huge category. Sedatives, painkillers, anticholinergics, steroids, withdrawal from alcohol or benzodiazepines is a classic cause too.
Infections like septicemia,
Big one, especially in the elderly.
intracranial issues, head injury, stroke,
Yes, anything directly affecting the brain structure or function.
and even things that seem less dramatic like severe sleep deprivation or extreme heat.
Absolutely. It really highlights how sensitive the brain is and how interconnected our body systems are.
Wow. Okay, so given that huge range of causes, how is it managed?
The absolute priority, number one, is to identify and immediately correct the underlying cause or causes.
Makes sense.
So if it's hypoglycemia, you give IV dextrose, sugar. If it's Wernicke's encephalopathy from thiamine deficiency, you give high-dose thiamine before glucose. Oxygen for hypoxia. Treat the infection. Stop the offending drug.
Right, target the root.
Exactly. And alongside that, you need symptomatic measures. Keeping the patient safe, reorienting them frequently, ensuring adequate hydration and nutrition. Sometimes medications are needed for severe agitation or psychosis, but very carefully. Low-dose benzodiazepines or antipsychotics might be used, but with real caution, especially in the elderly, to avoid worsening confusion or sedation.
So treat the cause first, then manage symptoms cautiously.
That's the core principle.
Okay, so we've explored delirium, that acute, often dramatic, fluctuating state. But what about when the brain's decline is more gradual? A slow erosion over months or years, but crucially without that clouding of consciousness we just talked about.
That's often where we enter the realm of dementia.
Right, dementia.
And you've hit the key distinction right away. In dementia, usually there's no impairment of consciousness, unlike delirium. The person is typically alert. The core features revolve around a progressive decline in intellectual functions, what we call cognitive abilities.
Memory being a big one.
Memory is central, especially impairment of recent memory in the early stages. Difficulty learning new things, remembering recent events, remote memory, past events, often stays intact longer. You also typically see a deterioration of personality, changes from their previous self, maybe apathy, irritability, or loss of social graces, often a decline in personal care and hygiene.
And it impacts daily life significantly.
Yes, it's a global impairment that interferes with their ability to function in daily activities, work, social life, relationships. There's also usually impairment of judgment, poor decision-making, sometimes poor impulse control, and difficulty with abstract thinking, understanding concepts, planning, problem solving.
Our sources also mention things like emotional lability, kind of swinging emotions.
Yes, rapid exaggerated shifts in mood can happen, crying easily, or becoming suddenly irritable.
And something called a catastrophic reaction.
Ah, yes. That's when someone with dementia becomes suddenly very agitated, maybe angry or tearful, when confronted with a task that's now beyond their cognitive capacity. It's like a short circuit of frustration and overwhelm.
That must be difficult for families to witness.
Extremely difficult. Later in the course, you might also see things like incontinence, and various physical neurological signs can emerge, depending on the specific type of dementia.
So how is dementia diagnosed? Is it also clinical?
Primarily, yes. The diagnosis is clinical, based on the history, the pattern of decline, and mental status examination. But laboratory tests and brain imaging are crucial to identify or rule out specific causes. The diagnostic criteria, like ICD-10s, require evidence of decline in both memory and thinking, severe enough to impair personal activities of daily living.
Okay.
And critically, clear consciousness, though delirium, can sometimes be superimposed on dementia, which complicates the picture.
Right.
And the decline needs to have been present for at least 6 months to meet the criteria for dementia. This duration helps distinguish it from more transient conditions, and it leads to some really important differential diagnoses we need to consider.
Like what else could look like dementia?
Well, first, just normal aging. We all get a bit forgetful as we get older, right?
Sure, the senior moments.
Exactly. But what's sometimes called benign senescent forgetfulness doesn't significantly impact social or occupational functioning. Dementia does. The severity is key. Second, we absolutely must distinguish it from delirium. We've touched on this, but it bears repeating.
Acute onset, fluctuating course, clouded consciousness.
Precisely the hallmarks of delirium. Dementia is typically insidious onset, progressive course, clear consciousness. That distinction is vital.
Okay.
And third, a hugely important one, depressive pseudodementia.
Pseudodementia. Sounds like false dementia.
That's exactly what it means. Severe depression, especially in older adults, can present with symptoms that look remarkably like dementia: poor concentration, memory complaints, apathy, slowed thinking.
So how do you tell the difference? That sounds tricky.
It can be, but there are clues. A key one is how the patient talks about their memory problems. Depressed patients often complain bitterly about their memory loss, emphasizing their failures. They might say, "I don't know," frequently during testing.
Okay.
Whereas patients with true dementia often seem unaware of their deficits, or they minimize them. They might try to confabulate, make up plausible-sounding answers to cover the gaps when confronted with a memory question.
Ah, that's a fascinating difference in presentation.
It is, and distinguishing this is absolutely critical, because depression is highly treatable. Identifying pseudodementia means someone might get effective treatment for depression and see significant cognitive improvement, whereas misdiagnosing it as dementia could lead to therapeutic nihilism.
That insight about pseudodementia feels incredibly valuable. A real aha moment.
Oh.
Okay, so once we're fairly sure it is dementia, are there different types?
Yes, many different types based on the underlying cause. The sources mention a broad distinction sometimes made between cortical and subcortical dementias.
Based on where the main damage is in the brain.
Exactly. Cortical involving the brain's outer layer, like Alzheimer's, often affecting language and memory more prominently early on. Subcortical involving deeper structures, like in Huntington's or Parkinson's disease dementia, often with more prominent motor symptoms early on. But let's talk about some specific common types. Alzheimer's disease is by far the most common cause, maybe around 70% of cases in places like the U.S. It's largely a diagnosis of exclusion. There aren't specific diagnostic clinical features or definitive lab tests for it while someone is alive.
So you rule out other causes first.
You rule out everything else treatable or identifiable. Autopsy findings are characteristic, though. Things like cortical shrinkage, enlarged ventricles, and those microscopic amyloid plaques and neurofibrillary tangles. Chemically, there's a significant decrease in a key neurotransmitter for memory, acetylcholine. That's why some treatments, cholinesterase inhibitors like donepezil or rivastigmine, aim to boost acetylcholine levels.
Right, helping the brain cells communicate better.
Essentially, yes. And another drug, memantine, works on a different chemical system, the NMDA system, thought to offer some neuroprotection.
Okay, Alzheimer's is the most common. What's next?
Second most common, maybe 10–15%, is multi-infarct dementia, also called vascular dementia. And this one is incredibly important because aspects of it can be preventable or treatable. It's caused by multiple small strokes, or sometimes larger ones, disrupting blood flow to the brain. So it often has an abrupt onset or periods of sudden worsening. The clinical course is often described as stepwise deterioration.
Like a stepladder pattern, not a smooth decline.
Exactly, a stepladder pattern. And the course can fluctuate. It's very commonly associated with hypertension, high blood pressure, and often there's a history of previous strokes or TIAs, mini strokes. Treatment here really focuses on managing the vascular risk factors, controlling blood pressure, managing diabetes, stopping smoking, maybe using blood thinners to prevent further strokes and slow progression.
That makes sense. Prevent the cause. Are there other treatable ones?
Yes. Another vital reversible cause mentioned is hypothyroid dementia, an underactive thyroid.
Really, low thyroid can cause dementia.
It absolutely can.
Hmm.
And the crucial point here is that prompt treatment with thyroid hormone replacement, if started early enough, the sources suggest within about 2 years of symptom onset, can lead to complete recovery of cognitive function.
Wow, complete recovery. That's huge.
It is. It's why thyroid function tests are standard in any dementia workup. Then there's AIDS dementia complex, or ADC. Affects a significant proportion of people with advanced AIDS, maybe 50–70%.
What does that involve?
It's typically a triad of cognitive deficits, behavioral changes, and motor problems like clumsiness or weakness. Dementia can even be the initial presentation of AIDS in some individuals. It's caused by the HIV virus itself being neurotropic. It can cross the blood-brain barrier and directly damage brain cells.
Okay. And another specific type mentioned is Lewy body dementia.
Yes, dementia with Lewy bodies, or DLB. It's now thought to be the second most common degenerative cause after Alzheimer's, maybe around 4% or potentially higher.
What makes it distinct?
It has some really key features. One is fluctuating cognitive impairment. People can have periods of relative lucidity alternating with significant confusion, sometimes changing quite rapidly. Another hallmark is recurrent, well-formed, and detailed visual hallucinations, often of people or animals.
Visual hallucinations, like in delirium.
Yes, but here they tend to be more complex and occur with clear consciousness, unlike in delirium. Parkinsonian motor symptoms like stiffness, slowness, tremor are also common. And a really crucial feature is something called neuroleptic sensitivity syndrome.
What's that?
People with DLB are often exquisitely sensitive to traditional antipsychotic medications, neuroleptics. Even small doses can cause severe worsenings of Parkinsonism, confusion, sedation, or even a dangerous reaction resembling neuroleptic malignant syndrome.
So using those drugs is risky.
Extremely risky. It's a major diagnostic clue and a critical management consideration.
So with all these different types and complexities, when someone is navigating these diagnoses, what does this all mean for their care and for their family?
It really means that the initial phase is all about thorough investigation, doing the test, blood work, imaging to find or exclude those treatable or specific causes. Then the absolute cornerstone of management is to treat the underlying cause if one is found and is treatable.
Like blood pressure for multi-infarct or thyroid hormone for hypothyroid dementia?
Exactly. Control the hypertension, give the thyroxine, stop the offending medication, manage the infection. Beyond that, it's about symptomatic management. Environmental manipulation can be huge, keeping the environment familiar, calm, well-lit, using routines, memory aids. Supportive care for both the patient and, crucially, the caregivers is essential. Education, support groups, respite care. For specific symptoms like anxiety, depression, or sleep disturbance, medications might be used, but always starting low and going slow. For more severe behavioral issues or psychotic symptoms, again, extreme caution with antipsychotics. We know they carry an increased mortality risk in elderly patients with dementia, particularly related to stroke.
That increased risk is a serious concern.
It is. And they should absolutely be avoided if Lewy body dementia is suspected because of that severe sensitivity we talked about. Sometimes newer, atypical antipsychotics are tried in very low doses if absolutely necessary, but always with close monitoring and after trying non-drug approaches first.
Okay, a very careful, individualized approach is needed. We've covered the acute crisis of delirium and the chronic decline of dementia. Now, let's explore organic amnestic syndrome. This seems to carve out a very specific problem. Memory loss due to a physical cause, but without the clouded consciousness of delirium and without that global decline in thinking and personality we see in dementia.
You've absolutely nailed this unique profile. It's a selective impairment of memory. The memory problem here is quite precise, quite characteristic. There's a severe inability to learn new material that's anterograde amnesia. So they can't form new memories effectively. And often there's also impaired ability to recall past memories, particularly more recent ones, that's retrograde amnesia.
But their immediate memory is okay, like repeating digits.
Yes, exactly. Immediate recall, just holding information in mind for a few seconds, remains intact. That's a key distinguishing feature from dementia, where immediate memory can also be affected. Another interesting feature, especially in the early stages, is confabulation.
Ah, confabulation again, making things up to fill the gaps.
Yes, filling in memory gaps with plausible but imaginary events or details, often delivered quite convincingly. This tends to decrease or disappear as the condition becomes more chronic.
So how is this diagnosed?
Again, it hinges on demonstrating this specific pattern of memory impairment, severe recent memory loss, variable remote memory loss, but intact immediate recall and having objective evidence of an underlying brain disease or injury. The damage typically involves specific brain structures critical for memory consolidation, particularly in the diencephalon, like the thalamus and mammillary bodies, or medial temporal structures like the hippocampus. ICD-10 criteria emphasize this memory pattern, the absence of global intellectual decline or clouded consciousness, and that evidence of brain disease. Differential diagnoses include things like transient global amnesia, which is a temporary episode of similar memory loss.
And what causes this specific memory syndrome? The sources highlight one major cause.
Yes, a key cause, particularly stress, is thiamine deficiency, vitamin B1 deficiency,
Which is often linked to.
most commonly due to chronic alcohol dependence, which leads to poor nutrition and impaired thiamine absorption. This results in Wernicke-Korsakoff syndrome.
Oh, okay, I've heard of that. How does it work?
You can think of Wernicke's encephalopathy as the acute phase, often presenting with confusion, eye movement problems, and difficulty walking, ataxia. It's a medical emergency requiring immediate high-dose thiamine. If Wernicke's is not treated promptly or fully, it can transition into the chronic phase, which is Korsakoff's syndrome. That's the persistent organic amnestic syndrome we're discussing, the profound memory impairment.
So Wernicke's is the acute delirium-like phase. Korsakoff's is the chronic amnesia.
That's a good way to conceptualize the progression, yes. But other things can cause it too, anything damaging those key memory circuits in the inner core of the limbic system.
Like what else?
Head trauma, certain surgical procedures near those areas, periods of severe hypoxia or ischemia, lack of oxygen or blood flow, specific types of strokes affecting those structures, infections like herpes, simplex encephalitis, which targets the temporal lobes, and certain brain tumors in those regions.
And what about management? Can it be treated?
Well, treating the underlying cause is crucial, of course, like giving high-dose thiamine for Wernicke-Korsakoff, both acutely and often long-term supplementation. But unfortunately, once the amnestic syndrome is established, especially in Korsakoff's, treatment often isn't very effective in reversing the existing memory deficits. The goal becomes more about preventing further deterioration and helping the person adapt using compensatory strategies.
So the prognosis isn't great for memory recovery.
Often, no. The prognosis for significant memory improvement is frequently poor, though some slow, partial recovery can occur over time in some cases. Rehabilitation focuses on structure, routine, and external memory aids.
Okay, a very specific and often challenging condition. Let's broaden our lens now, as you mentioned earlier, to this sort of miscellaneous group. Other organic mental disorders. What ties these together?
These are conditions where you have a distinct mental health syndrome, like hallucinations, delusions, mood changes, anxiety, or personality changes, that is judged to be causally related to a specific organic factor. That factor could be a primary cerebral disease, like epilepsy or a brain tumor, or a systemic illness affecting the brain secondarily, like an endocrine disorder or an infection, or exposure to a drug or toxin.
And there's usually a clear link in time.
Yes, typically a clear temporal relationship between the onset or fluctuation of the underlying physical condition and the mental health symptoms. And often, crucially, the symptoms improve or resolve when the underlying organic factor is treated or removed.
Okay, let's maybe touch on a few specific examples from this group because they really illustrate the brain-body connection in some surprising ways. How about organic hallucinosis?
Right. This is characterized by persistent or recurrent hallucinations, usually visual or auditory, that are caused by an organic factor. But, and this is key, it occurs without the major disturbance of consciousness you see in delirium, and without the significant intellectual decline of dementia, or the prominent mood or delusional features of other syndromes.
So just the hallucinations, essentially.
Primarily hallucinations, yes. And interestingly, patients often retain insight. They realize the hallucinations aren't real, even though they experience them.
What causes that?
Causes mentioned include hallucinogenic drugs, of course, chronic alcohol use, particularly during withdrawal, alcoholic hallucinosis. Sensory deprivation can sometimes trigger release hallucinations, the brain creating its own input. and certain types of epilepsy, especially involving the temporal lobes.
Fascinating. What about organic catatonic disorder? Catatonia is usually associated with schizophrenia, isn't it?
It often is, but it can absolutely have organic causes too. This disorder presents with catatonic features like stupor, mutism, rigidity, posturing, or sometimes excitement directly due to an underlying physical condition. Management here has a specific consideration. Traditional antipsychotics should usually be avoided because they can sometimes worsen catatonic features or precipitate neuroleptic malignant syndrome.
Really? So what is used?
Benzodiazepines, like lorazepam, are often first-line treatment for catatonia, regardless of cause. Sometimes electroconvulsive therapy, ECT, can be very effective, especially if benzodiazepines don't work. Low doses of atypical antipsychotics might be considered cautiously later if needed for psychosis.
Interesting. Okay, how about organic delusional schizophrenia-like disorder?
Here, the predominant symptom is delusions, fixed false beliefs clearly caused by an organic factor. Again, it occurs without major disturbance of consciousness, orientation, or memory, and mood disturbance isn't the primary issue.
So it looks like schizophrenia, but isn't. How do you tell them apart?
A key distinguishing feature mentioned is that Schneiderian first-rank symptoms, things like thought insertion or withdrawal, which are considered classic for schizophrenia, are usually not seen in organic delusional disorders. The content of the delusions might also be less bizarre sometimes.
And the causes?
Various substances like amphetamines or cocaine intoxication or withdrawal, certain types of epilepsy, particularly complex partial seizures, neurological conditions like Huntington's disease, even nutritional deficiencies have been implicated.
Okay, and organic mood or affective disorder. This sounds like depression or mania caused by a physical issue.
Exactly. A prominent and persistent disturbance in mood depression, mania, hypomania, or a mix directly caused by an underlying organic factor. Again, without major issues in consciousness, orientation, or memory dominating the picture.
What kinds of things trigger this?
Oh, a huge range. Many medications are notorious for causing mood changes. Corticosteroids, for example, can induce hypomania or mania, even psychosis. Drugs like reserpine were historically linked to depression. Endocrine disorders are classic culprits. Thyroid problems, again, both hypo and hyperthyroidism, Cushing's disease, Addison's disease, and many CNS disorders. Parkinsonism is often associated with depression. Stroke can cause post-stroke depression or sometimes mania, multiple sclerosis, brain tumors. The list is long.
And I imagine the caution about antipsychotics in stroke or dementia patients applies here too if mania has psychotic features.
Absolutely. That increased risk needs careful consideration.
Okay, nearly there.
Yeah.
Organic anxiety disorder, like panic attacks from a physical cause.
Precisely. Persistent generalized anxiety or recurrent panic attacks, or a mix, that are judged to be the direct physiological consequence of a specific medical condition or substance. Common causes include intoxication with stimulants like cocaine or caffeine, withdrawal from alcohol or sedatives, endocrine issues like hyperthyroidism or pheochromocytoma, cardiac arrhythmias causing palpitations that trigger panic, even some brain tumors.
And finally, organic personality disorder. This sounds really profound, a change in someone's actual personality.
It is profound. It involves a significant alteration of the individual's pre-morbid personality patterns, how they were before the illness. This alteration is due to brain disease, damage, or dysfunction. Again, it occurs without major disturbances in consciousness, orientation, memory, or perception being the primary problem.
What kind of personality changes?
It can manifest in various ways: poor impulse control, emotional polarity swings, marked apathy and indifference, suspiciousness or paranoid thinking, or socially inappropriate behavior. The sources mention fascinating specific syndromes linked to particular brain areas, like frontal lobe syndrome.
The brain's CEO, right?
Exactly. Damage there can cause disinhibition, poor judgment, impulsivity, jocularity, lack of social tact, or conversely, an apathetic type with lack of motivation, indifference, and blunted emotions.
So damage in the same area can cause opposite-looking problems.
Yes, depending on the exact location and nature of the damage within the frontal lobes. Another one mentioned is temporal lobe syndrome, sometimes seen with epilepsy, characterized by things like egocentricity, stickiness in conversation, viscosity, hypergraphia, excessive writing, altered sexuality, and sometimes heightened religiosity or philosophical interest.
Wow. These really show how intimately our self is tied to brain function.
They absolutely do. And across all these varied other organic disorders, the management theme remains consistent.
Let me guess. Treat the underlying organic cause.
You got it. First and foremost, identify and treat the underlying physical condition whenever possible. Then, manage the specific psychiatric symptoms carefully, using medications or therapy as appropriate, always considering the context of the underlying illness.
So bringing this all together,
Ah,
what does this deep dive really mean for us? As we wrap up, it just seems abundantly clear that brain dysfunction, whether it's from a sudden infection, a medication side effect, a chronic illness, or a degenerative disease, can manifest in this huge, immense range of ways that can really look like purely psychological or behavioral issues. It just powerfully underscores why that careful, thorough investigation, that medical detective work looking for underlying physical causes, is so absolutely crucial when evaluating any mental health concern, especially given the potential for treatability and sometimes even full recovery in many of these physically driven conditions.
you've really hit the core insight there. For you, our listener, I think understanding these distinctions helps us all appreciate that intricate, really inseparable connection between our physical brain and our mental experience. Our thoughts, feelings, behaviors, they don't happen in a vacuum. It emphasizes why a comprehensive, holistic approach is just so critical in any psychiatric evaluation, always considering the body's role, the brain's physical state. And maybe this raises an important question for you to think about. How does knowing about these distinct organic conditions potentially change your perspective when you encounter seemingly psychological symptoms, either in yourself or others? Does it make you pause and wonder about other possibilities?
That's a great question to ponder. And maybe one final provocative thought, building on that threshold phenomenon you mentioned with delirium. Consider how that concept, where multiple small, maybe seemingly unrelated factors combine to cross a tipping point and cause a major change, might apply not just to delirium, but perhaps to other health conditions, maybe even aspects of well-being in your own life or in the lives of people you know. A fascinating thought to mull over, isn't it? Thank you so much for joining us on this deep dive today. Welcome